think we're going to start, if that's okay. Is that all right, if everyone wants to take a seat? So I think, I'm hoping all the people online can hear me. I can see Emma, and she's nodding her head, so that's good. So I am not Fiona Blackall, as you can probably see. My name is Natalie Cook. I'm a senior clinical lecturer at the university and a medical oncologist at the Christie. And it's my pleasure to introduce today. We're joined by some fantastic health economists from the University of Manchester. And really, this is all about understanding more about health economics, increasing collaborations in health economics, and obviously I know there's a lot of people in this room that will be very interested to hear how we can work more with and understand more about health economics with our research. So I've not really gotten to say the agenda is online here. We're going to go through all this. We have a break at 11:30, and then we'll also have lots of opportunity for questions and answers at the end. So obviously, if there are any burning questions to ask at each talk, that's great. But I think there's going to be a Q&A at the end, and then lunch afterwards. So I'm going to hand over to Stuart, who's going to chair the rest of today, I think. So thank you.
Okay, so I'm instantly going to mess up the tech by switching to Mentimeter. So make sure I share this. That's the slides, isn't it?
Yeah, it should be if you're on Windows.
It's just down there. Okay, yeah. Okay.
And then we'll just drag it to.
Okay, great, thanks. So hi everyone, my name is Stuart Wright. I'm a Senior Research Fellow in Health Economics at the Centre for Health Economics, and here today just to talk about our Economics of Cancer group that we've recently set up, which is led by myself and Gabriel and supported by Catherine here. And we wanted today basically to come and introduce some of the methods that we can offer to cancer research, some of the projects that we've worked on before, hopefully give people some ideas for new collaborations and different sort of studies that can help support cancer research across the university. So a little bit about us. So we have probably in the Centre for Health Economics about 30 health economists, and we have a really large volume of work in cancer. So I have created this kind of tool that I'm going to share after the meeting, which will allow people to sort of explore the different kind of research that we do that across the different stages in the sort of cancer pathway, from screening and diagnosis, prevention to treatment and living with and beyond cancer. We work across, I think we're now up to about 10 or 11 different types of cancer, and I think there's about 16 of us actually now since I last updated this as well. So, and we offer a wide variety of methods to support cancer research. So here's an example of the kind of the different work that we do across different cancers. So we have a large volume of research in breast cancer, as well as cervical and lung. Also in multi-cancer early detection tests is an area that we're really interested in, with the complexities that are inherent in offering those tests. And so we're probably more specialist in kind of the prevention and the screening side of cancer research. But we have done work across the pathway, as I sort of mentioned. So before this workshop, I asked some questions on the registration form about your experience of working with health economists in your research. And a lot of people have some sort of understanding, have worked with health economists before, but also a lot of people quite new. So, hopefully today will give you a good introduction to what we do and what we can offer. Again, sort of, large volume of people haven't worked with health economists before. And really, what you want is to understand, what we do in cancer. So hopefully that's what we'll achieve today. So I wanted to start today by sort of talking a bit about some of the things that underpin health economics and why we do it, and also sort of to dispel some of the myths that are prevalent around health economists and what we do. So we have a Mentimeter today, so I wanted to ask you some questions to start off with. And also we'll also leave this open, so there'll be a Q&A part at the end of this as well. So if you want to ask any questions on Mentimeter throughout, you can do those and we'll be able to address those at the end. So firstly, I wanted to ask what you kind of think we as health economists are most interested in research, kind of resource use, costs, clinical effectiveness, quality of life. What are we looking at when we do our research? Now, I feel like I've made some of these quite easy, right? Whenever there's an all of the above answer, it's usually that one, and you're right. Yeah. So our health economics Bible, our textbook that we always refer to, is by a researcher called Michael Drummond, and he has this definition which every health economist knows off by heart, because our PhD theses is one of the first things we would cite. But when we're doing economic evaluation, when we're comparing different interventions, what we're doing is comparing different courses of action in terms of both their costs and their consequences. So yes, we are interested in resource use and costs, what the cost of a treatment or a test is to the health system, but we're also interested in the health outcomes of people. So that might be a clinical benefit, but also maybe negative health outcomes like side effects, false positive results from tests, and how we weigh all those things up together. So we're quite generalist in our methods. We look at lots of different health research to look at all of those consequences of changing the way we do things in research and in clinical practice. So we've said, well, cost is one of the things that we are interested in. Why do you think health economists are interested in cost particularly? So this is a little bit small on the screen, but the answers here are, well, we want to be efficient. That means making things as cheap as possible. Is it because when we spend money on one group of people, that means we can't spend money on someone else? Or is it just because we spend, what, £120 billion a year on the NHS budget, and that's... Okay. Yeah, so again, you guys are right. So the reason health economists are really interested in cost is because of this notion of opportunity costs. So broadly speaking, the NHS has a fairly fixed budget. It goes up by a few percent each year with sort of political decisions. But if we're funding, say, a new cancer treatment that costs, say, £5,000 a month to treat a patient, that money has to come from somewhere else within the health system. There's not just an additional sort of funding that comes from central government. So we have to take some kind of something away some kind of treatment or intervention that we're doing for someone else. They're going to lose funding, so there's a health loss for those people. So what we are interested in, particularly about cost, is not trying to be cheap, not trying to minimize costs. It's trying to weigh up the consequences for not only the sort of patient groups that we're looking at who are going to benefit from a new intervention, but also the health that's going to be lost by someone else in the health system. And that might not be, say, that we're just going to stop treating, offering this drug to people because we have to offer this new drug, but it might be things like, longer waiting lists, lower staffing levels in A&E. These are kind of consequences that finance managers are having to make to sort of accommodate new funding, new interventions. And so this is probably one of the most famous things that the health economists will produce. There's something called a cost effectiveness plane. So when we look at a new intervention, we look at its the health outcomes, which we sort of measure often in this thing called quality adjusted life years, which we'll talk about a bit more in some of the future presentations. And we look at the cost of the treatment. So when we've got a new intervention and it's produces more health and it's cheaper, that's great. That's the our ideal situation. Patients will benefit, and we're going to free up some resources for other people in the health system. If we have an intervention that's more expensive and worse for patients, and obviously we don't want to do that because we're going to make everyone worse off. But we have this question of what to do, in the top right and the bottom left quadrants, where we have something that's better but more expensive, or worse but cheaper. So you imagine something like a biosimilar drug or some kind of generic drug might be cheaper, but might maybe not be as effective. And so we need to have some rules that judge whether we should use those interventions. And that's where the kind of the cost effectiveness threshold comes in. So you might have seen in the news about with the American drug pricing negotiations that the NICE threshold has gone up to £25,000 to £35,000 of medicines. And there are other thresholds that are used by other decision-making bodies as well. And we're having lots of arguments about this at the moment as health economists about which values we should use to judge whether something's cost effective. So linked to that, one of the other things I wanted to say is if something is not cost effective, that doesn't mean we don't think those people are important. So you have a new drug for breast cancer patients, and we look at all the evidence and we say this is not cost effective. That doesn't mean that the value of that person's life is not worth, the money. It's that by funding this thing, we're going to take away more health from other people in the system. And so, it's this real balancing act of, just that there are limited resources and how do we balance the needs of different patient groups. We don't want to say stuff is not cost effective, so we don't like saying patients should not have this. So one of the things we'll talk about today is about how health economists can get involved earlier on in the sort of intervention development pathway as well. So, traditionally people come to us right at the end. We've got this great new test, new treatment. We've been working on it for 17 years. It's the translational pathway, and we come along at the end and say, "Oh no, sorry, it's not worth it. It's too expensive. The benefits don't justify it." But we can actually sort of do early modelling. We can get involved at an early stage to sort of help say, okay, for this test, maybe we need to get the specificity up because we're having too many false positive results. We need to, see if we can, help, get some more evidence in this area to make this argument for bringing this in, and that is something that can hopefully help, us contribute and bring in more things to sort of approval through sort of bodies like NICE or the National Screening Committee. So I've just given you the answer to that in my spiel that I've just given, but my last question was going to be at what stage, should you be getting health economists involved in your research? I'll let you answer, but as I say, I've just given you the answer to that. Yeah, so you can pick as many as you want here, but at any stage really, from really sort of early stages to, from identifying gaps where there's a real need, in terms of a benefit that patients, are missing, unmet need for an intervention, all the way through to sort of approval of a technology at the end of the pathway. So health economists is for life, not just for Christmas. So rather than saying, is this fixed or designed intervention cost effective, we'd much rather say, how can we design an intervention that will be cost effective when we get to that stage? Because the other thing, is that, lots of interventions never make it to that stage as well. So there's also value in potentially saying, maybe actually this is not a line of research that is going to, go to fruition, and we should focus on other things as well. So, okay, so our objectives today, just to finish off, are going to be to just raise some of the more awareness about some of the methods we use to answer some of these questions, to identify some more collaborations. We've put all of our email addresses on all our slides today, so if you want to contact anyone, please do, or contact me and I can guide you to the right person. And yeah, as I say, get involved at an earlier stage as well, because we want to be involved earlier on in the pathway, so we can make a bit more of a difference. And I will leave this open as well, this Q&A, so if you have any questions throughout, hopefully you should be able to just submit text questions, and at the end we'll try and look through these and answer, or put your hand up and we can do it in person as well. Okay, and I will try and pass back over to Gabriel. Yeah. Check that one. I need to reshare online. This is the last time I'm going to do this. Okay, I think that's sharing. So.
Just drive it to the-
Awesome, thank you. All right, thanks for that, Stuart. I'm going to talk to start with about a particularly prevalent item in the Health Economist Toolkit, which is decision analytic modelling and how that fits into economic evaluation. And Stuart's been generous enough to give me a little bit more time to talk about that than some of the other topics today, because it sort of underpins quite a lot of what we do. So just to tell you a little bit about me, well, ignoring some prehistory that you don't want to hear about, my first job in this area was with the University of Exeter, where I was doing research literature review work, really, that was largely used to feed technology appraisals at NICE. And after doing that for a few years, I went and worked within NICE itself for a long time. In particular, I was doing essentially the kind of decision modelling I'm going to talk about today within the guidelines programme. And then in the last 5 years, moved back to academia and now have the role within Manchester Centre for Health Economics. But I couldn't keep away. And I now sit on a technology appraisal committee for NICE, which is interesting for me because in all that previous work, I've been feeding those committees, and suddenly I find myself as a decision maker in that realm, which is novel. Throughout all that work, I've done a bunch of stuff on various cancers, particularly brain and breast and some hematological cancers, and liver has been something that I've looked at quite a lot, fair amount of lung as well. That's the background of where I come from. Stuart talked a lot about cost effectiveness in what he said, and economists tend to talk quite a lot about cost effectiveness. I prefer not to use those words whenever I can, because I think it is a source of misunderstanding of what it is we think we're playing at. What I do like to talk about is a simple negotiation, as Stuart was talking about, between the benefits of a course of action, the harms of a course of action, and the costs of a course of action. And that definition from the Mike Drummond textbook that Stuart read out is a good start from here, in that it emphasises that health economics, cost effectiveness analysis, is a fundamentally comparative discipline. Nothing can ever be good value in and of itself. It can only be good value compared with something else you could do, or a whole range of other things you could do. But of course, we're working across different dimensions here. We're interested in things that are good, things that are bad, and costs you could think of from an economics perspective as just another harm, really, a harm to the system, as Stuart explained. But within that, if you've got these different dimensions, you need a way of exploring trade-offs between them, a way of weighing up your apples and oranges. And the Health Economics Toolkit is a way that I would argue is well suited for making those kind of decisions. You'll have clocked from my introduction that personally, as an economist, I'm quite nice coded. There are economists in this country who pursue different philosophies, but what I'm likely to say is probably quite representative of the methods that are advanced in NICE, for better or worse. And one of the things that NICE likes to do is to think about weighing up benefits and harms in a single metric, which Stu's mentioned, the quality adjusted life year, which is conceptually really simple. If we draw a graph like this, and along the horizontal axis we put time, which we'll measure in years, then on the vertical axis we're going to put something that we'll call quality of life or utility. Because I don't have time today, though we'll happily get into it another time, I'm sure, I'm not able to go into detail about the ways in which economists value quality of life. So you have to take it on trust from me that we believe we can put it on a scale which ranges from 1 at the top, which is equivalent to perfect health, best imaginable health for any person, and 0 at the bottom, which is equivalent to death. So anything exists on that continuum. And we can argue about whether qualies are mathematically optimal or in terms of how we measure that vertical axis, but I think it's pretty indisputable that if we want to measure the effects of competing courses of action, then the 2 things we are always going to be interested in is how long do people live for and what's it like to be alive during that process. So in this world, I'm imagining a current treatment that exists, and I'm imagining this is some kind of medical treatment for an existing condition. We can see to start with that the population starts off at a less than perfect quality of life. They're already experiencing some kind of condition which impairs their quality of life. The medical treatment maintains them for a bit, and then their quality of life falls off until they die. So it's just the area under that curve is our qualities. It's just integrating that out. And we're interested in amount of time multiplied by quality of life while alive. If we imagine that a second treatment comes along, and maybe I'm imagining this is a surgical treatment for the same condition, what we see is that you start off in the same place, and then you get a drop in quality of life. Maybe surgery is unpleasant to go through and recover from, but if it works, then we are restoring the population to a greater level of health than they were in to start with, and they may even live longer as a consequence. So the area under that curve is our qualities under the new treatment. We've got an area of quality loss there and an area of quality gain there, and we would say that on average, because the quality gain is bigger than the quality loss, the new treatment generates more qualities than the existing one. So that's conceptually how you can imagine how we can begin to bring together all sorts of various outcomes and try and weight those in a way that gives the lifetime consequences of the decision. So the framework in which we might commonly do that is something that we would call a model. I'm pulling this out of a different standard health economics textbook. I'm not going to read through it all, but I'm going to highlight a couple of bits. So a systematic approach, recognizing that every decision we make is under uncertainty, coming up with some kind of mathematical representation of a reality, which must include the consequences of some alternative options. And those consequences will be costs and a variety of different outcomes. Let's just call them outcomes. And then for any given option, we're interested in the expected outcomes, which is the sum of the outcomes for each consequence weighted by the probability that you experience any of the consequences. That is a high-level definition of what a model is, and there are many, many different ways of doing it, but everything I'm going to talk about today pretty much falls under that definition as a model. So the question arises, why do we need it? If we've got good empirical data, why do we need to simulate a world and have little virtual people running around a computer to tell us whether to help us make a given clinical decision at a population level? I'll admit right up front that a lot of what I'm going to say you could find in a paper from very nearly 30 years ago, which I think is still the best introduction to this, written by a fellow called Martin Buxton. But if we're saying we exist in a world where we have some empirical data, some trials. Why would we need a model? Not instead of that trial, but in order to make derive best sense from that evidence. So the first reason for that is that, in the words of a friend and collaborator of mine, Amanda Adler, life is long, but trials are short. We will never have a full follow-up of the full lifetime of the people that are affected by a decision. And even if we were to have that, we would have information about care that took place a long time ago. So we will always want to know the lifetime consequences of the decision we're making. And I'm fond of saying that health economists extrapolate for a living. And modeling gives us a way of doing that. So here is some data from a project we're really happy to be working on with colleagues here, which is Rapid RT, looking at innovative approaches to radiotherapy in people with lung cancer. These are survival data from that study, and they're arrayed according to tumor grade and performance status. And you can see that, particularly if we're looking at the people with lower grade tumours and better performance status, we have relatively immature data from which to infer what the consequences of different treatments might be. And what we might commonly do as economic modelers is to find parametric functions that fit through those curves, so we can project off to the time horizon that we need in order to draw our conclusions. So there's a bunch of different statistical fits there, and we might choose a better one and use that as a basis for our simulation. This is all work in progress, so we haven't really made those choices yet, but that's the kind of processes we go through. Something else about trials is that they often tell us something about short-term outcomes that aren't really directly patient relevant. Actually, cancer is probably better placed than a lot of other clinical areas in that regard. A lot of cancer trials do tell you about overall survival, and they do tell you about events that happen to patients that patients care about. Whereas in a lot of other areas, you might have short-term measures. You might change someone's blood pressure. Well, a person doesn't directly care whether their blood pressure has changed. They care about the consequences of hypertension. So maybe cancer is a bit better off than other areas than that, though, especially when it comes to the early stuff that Sean will talk to you about a bit later. Maybe we are looking at constructing relationships between short-term measures and what that might mean in the long run. I had to dig into my archives to find a decent example of this. This is something I did in Exeter, where we looked at tyrosine kinase inhibitors, which were at that time new for chronic myeloid leukemia. And for that, there was no real evidence about overall survival there, but there was some evidence about the probability of major cytogenic response to the various treatments. And there was some evidence about how long people might live conditional on having those kinds of responses. So we were able to put a model together that made use of that evidence and came to the best possible estimate of the long-term survival we needed to project. Another problem when it comes to decision making directly from empirical evidence is your evidence is seldom going to include everything that you might do within the space. A randomized trial is often drug X versus placebo. A screening trial is screening versus not screening. And there might be dozens of different ways you can do these things. And in a model, we can simulate as many different approaches as we can imagine, and we can find evidence for. So an example here is Stuart's breast screening model, which simulates, I mean, this is only 6 different possible strategies, including no screening. And that in itself I think looking back at the early trials on which mammographic screening is founded, there's like 50,000 people per arm, I think, in some of those. I think given how close the differences are between some of these approaches, you probably need 1 million people if you wanted to run this trial and get reliable information about the relative benefits of different approaches. Virtual people are an infinite resource. We can simulate as many of them as we need, and as many as we can find evidence to support. Another example, which is even broader one, is something I'm working on at the moment, which is a model looking at methods for surveillance for hepatocellular carcinoma in people with liver cirrhosis, where we say we're going to look at the frequency with which you look at people, the tests you use, the thresholds you apply to those tests where they're continuous, and stopping rules, and that factorially multiplies up to thousands of possible strategies, and I'm only limited by the computer that will enable me to do it. I think that threshold point is one that I'm particularly interested in this project and others. So here's a bunch of evidence that we've collected for the project showing the diagnostic accuracy of alpha-fetoprotein for detecting the presence of HCC, and the red line shows people who really did have cancer, and the blue line shows people who didn't. So as a function of threshold, what's the probability you'll get a positive test? Well, if we set our threshold down here, then we will have relatively good proportion of true positives on our red line, but we're also going to have a load of false positives as well. If we set our threshold right up here, we'll have very few false positives, but we're going to have relatively few true positives. We'll have a load of false negatives. How would you split the difference between that? I would argue this, wouldn't I? But I'd argue that the only way you can do that in a fully evidence-based way is to simulate out the lifetime consequences of those false positive and false negative diagnoses in particular, and to see what the net health effects of those are. And that's what we're doing in our model at the moment. Your evidence might well not be conducted in exactly the population you're interested in. It's a well-known complaint that particularly more high-powered randomized trials often focus on fitter, younger, less comorbid people than are seen in practice, and we can use lots of our techniques to simulate the target population. We're actually interested in start it off at the right age. One of the things we quite often do in NICE appraisals and the committee I work with is insist that the companies take the relative effects from their trials and apply them to a baseline expectation of survival or some other outcome that comes from data that are representative of the population in question, like SACT survival data. And it also gives us the opportunity to explore subgroups. So this is something we're working on at the moment, a project called Prostatect 2 with colleagues in primary care, looking at, again, it's a threshold question. At what level of PSA should GPs refer people with for suspicion of suspected prostate cancer to secondary care? And we're building a relatively simple model that enables us to simulate out those false negative and true positive consequences. But the important thing about this is we're doing it, we recognize that there's evidence that the optimal PSA threshold is likely to change according to how old the person is, their ethnicity, and whether they presented with lower urinary tract symptoms in the first place. So again, we've got like 50 different populations we're going to simulate through here to try and find those thresholds. And then finally, the really important thing to emphasize is that models take all the uncertainty in all their inputs and integrate it together to find decision uncertainty. So a trial will give you a confidence interval around a hazard ratio or whatever. But that in itself is only part of your global uncertainty about the right decision to make, and we can integrate all of that within our mathematical structure, and that might enable outputs like this, again from Stewart's model, where we can express the probability that certain treatments or certain approaches to screening in this case have the highest net benefit for the system. And do that in probabilistic terms that integrates all our uncertainty. So a reasonable question to ask is, why on earth should we believe in these pretend people in a box that you're simulating through your system? And are those processes reliable to inform decision making? So one bon mot you may very well be familiar with is George Box's idea that all models are wrong, but some models are useful, which emphasizes that in their nature, models are about abstraction, simplification of a complicated problem and trying to find the things that drive the outputs. I rather like a quotation from a less famous, at least, writer who's a mate of ours in a different health economics group, a fellow called Ed Wilson, who just in a discussion of a paper comes up with this, which I really like, which says, don't judge a decision model against like the perfect reality. Judge it against what else you could do, which is to make ad hoc decisions in your head. And I would assert that all of us are modeling all the time. We're all weighing up different pros and cons of different approaches in our daily lives and also in clinical decision making. I don't think it's necessarily a very low bar to clear that if I build a model, it should be better than what a wise clinician can do in their head. That's quite a hard bar to clear. But one thing I will insist is the emphasis on transparency at the bottom there. That the least you can say about any model I build is that you can argue about it. I can be transparent about what assumptions have been made, all with input from clinical and patient experts, obviously. What assumptions have been made, what data has gone in, and what the structure is. And all those things are up for question if anyone thinks that better choices could have been made. So at its absolute least, we can guarantee that a model is going to be more transparent than ad hoc decision making. Here are a bunch of people working in modeling. It's basically the people sitting here, really. But most of us do some kind of modelling work within the Manchester Centre for Health Economics. These people are just some who've done some in recent years. That's me done. I'll hand over to Joe.
So I'm Joe Hilton. I'm a mathematical biologist by training. I've been in MCHE for about 2 years. So Gabriel's talked us through why we might want to do some kind of modelling. I'm going to go into a bit more detail on kind of how we model patient experiences, clinical pathways, and as you might guess, I'm really interested in that intersection between the biology and the economics. I'm also incredibly squeamish, hence why this is mathematical biology. Some economic modelling tends to look maybe more like accountancy than maths. And in general, cancer modelling is somewhere where you actually need a bit more mathematical sophistication. So when we think through a patient's cancer pathway, we need to think about different levels or different scales. So before someone develops cancer, hopefully the public health system is doing something to modify their risk of cancer. So that's happening beyond the patient at the level of health system and their environment. When a patient starts to develop cancer, that's due to events happening at the genetic level, at the cellular level, so within the patient. As cancer progresses, the tumour grows at the level of the patient starts to experience symptoms, and then the treatment acts at the intersection between the patient themselves and the health system. So we've got something where we need to keep track of what's happening at multiple scales. There's also a temporal dimension here. So the right thing to do for a patient depends on where they are in this cancer pathway. So ignore the axes here. These numbers are completely fabricated, but the shape is about right. So the right intervention, if you detect a cancer early, is going to be different to the right intervention if you catch a cancer later in its development. And so all this means that cancer is complex. So when we are doing decision analytic modeling, we need to keep track of this complexity. So our clinical models are models of what's actually happening between the patient and the health system, end up looking something like this. So we need multiple components to track these different factors. So we need some indication of what patients look like. So there's going to be some statistical analysis of data from patients. We need some mathematical modeling. So that includes population demography. That also includes biophysical models of tumor growth. And then we need random simulation. So we need to run all these patients through the computer and look at what is happening at the population scale as we implement different interventions. One thing we're, I think, becoming more and more passionate about within the Centre for Health Economics is software development. So in general, we're using R and now some Python to implement these models. That allows for these more sophisticated simulation models, and it also makes our work more reproducible and more shareable. So what are we actually doing in this space? Gabriel's also already mentioned some of our work on risk stratified breast cancer screening. This has been going on for nearly 20 years now. The main question we're interested in is the cost effectiveness of tailoring someone's screening to their predicted risk of breast cancer. So basically, if you've got someone who you think is at higher risk, should you screen them more often? And in terms of that open source software development, I've put a few papers up there in this space that have been published sort of within the last 10 years or so. But then also in the bottom left corner there is just a screenshot of a GitHub repository where we are kind of keeping track of this model development. So we're also doing some work on cervical cancer screening, specifically around self-sampling. So the idea is rather than going in and having a screening appointment with a clinician, patients could potentially do a home HPV test and then if they test negative for HPV, they would then not need to be invited in for a more invasive screening appointment. This adds an extra level of sophistication to our modelling in that because cervical cancer is in most cases post-viral, we need to combine our model of tumour growth and of the health system with a infectious disease transmission model. So this is looking a little bit more interdisciplinary than the breast cancer model. We're also currently doing some work in collaboration with some of the medical physicists here at the University. So this is on a project looking at the impact of hypofractionation, so giving fewer doses in a course of radiotherapy on carbon footprint. On the economic side of things, we're interested in what this means for resource use. So if you've got fewer patients coming in, or rather same number of patients coming in fewer times, what does that mean for things like staffing numbers and kind of how efficiently you can run your clinic. So where are we going in the future? We're interested in the use of image recognition software in breast screening. We're doing some work on preventative drugs. So, you know, if you give tamoxifen or an anastrozole to your higher risk breast patients, what does that mean in the long term? And then we're also going to be doing some work with researchers at Imperial on kind of more the public health side of things. So if you have kind of social interventions to improve uptake in low uptake communities, do you see better outcomes? On the methodological side of things, Stuart and I have a MSc student starting over the summer, looking at improving our methods for model calibration. We are continually trying to improve practices in the centre around open source software development. And then in the longer term, we'd like to move towards having a library of cancer screening models, which are just a bit more standardized than what we have now. So the team working in clinical modeling is mostly the same people that Gabriel showed. We also have Shiza, who's just sitting in the audience there and probably doesn't want me to point her out. And then Solly Yates, who's another research associate within MCHE. So with that, I will hand over to Amber.
Hello. So yes, my name is Amber, and today I'll be giving you a brief introduction into understanding preferences using discrete choice experiments, or otherwise known as DCEs. So DCEs are a research method that people use to understand preferences, and that can be of any relevant population. So you can look at preferences of the public, of patients, of clinicians, or even policymakers. So DCEs are based on the idea that individuals value a product or service through its specific features, or in DCE terms, we say attributes, rather than the overall item. And we rely on stated preferences. So we provide participants with different hypothetical options to choose between. Now, DCEs are embedded within a survey, and each participant answers a series of choice questions. And between the choice questions, we vary the attribute levels. And by varying these levels and seeing how choices change, we can actually analyze which of these attributes or attribute levels are driving choices. So here is an example that I've taken from our cervical screening project. So in this example, the features of the DCE are the detection rate, how the sample is taken, location, pain, contact with your healthcare provider, and screening frequency. So we presented participants with option A, option B, or no screening. And as you can see, each option is associated with a specific level. So in this case, option A is a smear test with 95% detection rate, while option B is a urine sample with an 80% detection rate. So what we want is for participants to read these levels and weigh these different levels up, and then make a decision between option A, B, and no screening. So this is the first choice task we gave participants. And here is the second. So as you can see, we have changed the attribute levels. So option A is now a vaginal sample and 90% detection rate, while option B is still a urine sample, but it's now an 85% detection rate. So we want participants to then make their decision again. And now in this project, we gave participants 10 choice tasks. And within each choice task, we varied these attribute levels. And so as I said before, by systematically varying these levels and looking at how their choices change, we can analyze what is driving their choices and therefore their preferences. Now, how do we actually conduct a DCE? It can be a very long and complicated process. So firstly, we need to identify the attributes. So here you need to balance including everything that is important to the population with their cognitive burden. Then second, we need to assign the levels to the attributes. And again, there's quite a lot of balancing required here because we need the levels to be plausible and realistic, but we also need a large enough range that we can detect a meaningful difference in preferences. Then we have the complicated experimental design. So this refers to the systematic way that we are varying these attribute levels. Next, the very fun part, we collect the data. This can be face-to-face, on paper, and online. Nowadays, it's most common to do it online because that is the easiest and cheapest way to get the largest number of participants. But depending on your target population, you may need to use a variety of methods. So for instance, I did a DC in stroke survivors, and here we used a combination of both online and in-person face-to-face. And then, as I've already talked about, we have the data analysis, which is regression analysis to analyze these preferences. Now, what can the results actually tell us? First of all, we can get the relative value of each attribute. So for instance, you might be able to say that swapping from a blood test to a saliva test will improve utility by X amount. And so here, the blood test and the saliva test are both levels within the same attributes. But we can also get trade-off between attributes. So for instance, people are willing to accept a 10% increase in risk of a false positive if it means that they can go to a specialist rather than a GP. Next, we have the willingness to pay. So people may be willing to pay Y dollars for a blood test with a GP, or if you're in England, pounds, because I still think in Australian dollars. And so this also requires including a cost attribute within the DCE. Then we have the uptake rate. So the percentage of people that will uptake a specific policy or healthcare scenario. And so this requires the inclusion of a no intervention option. So in the cervical screening example before, we had option B, option O, and no screening. And actually, this is also quite useful because then you can take the uptake rates and you can put them into the economic model. So it's a good way of showing how our methods can work together. Now, who is working in this space? We have Catherine over here. We have Stuart over here. As that means if you have any tough questions, you can ask them instead of me. Then we have me, Martin, and for fun, she's in the audience. Oh, and Groma. Okay, so as you've seen, as health economists, we work across a range of clinical areas. So here are some examples of our ongoing projects. We have the cervical screening one that I showed you before. We have one around public preferences for multi-early detection cancer tests. And this one is, next one is outside of cancer, but very interesting. So we're looking at the factors which influence clinician recruitment to the biologics register to try and understand why this biologic register is not representative of the people who are on biologics. And then just 2 examples of projects that I've previously worked on. One looking at public preferences for prenatal screening, and another looking at public preferences for genomics-informed risk-tailored cancer screening. So thank you. And if you have any questions, feel free to email me or talk to me in the break. Thank you.
There you go. Yeah. Hi, everyone. Good afternoon. My name is Christos Grigoroglou. I'm a research fellow at the Manchester Center for Health Economics. Today I will be talking about understanding cancer research use and treatment costs using routinely collected data. I'm very new to cancer research. I only started, well, this work was starting getting developed 2 years ago, but we had delays with getting the data. So one key question in cancer policy is whether new strategies to detect cancer early are cost effective. Diagnosing cancer earlier changes treatment pathways and affects survival rates and healthcare costs. And within a system of limited resources, this is very important. And if we want to do economic evaluation of cancer screening interventions, we need contemporary estimates of the cost of cancer care by stage of disease. So this piece of work runs a little bit in the background of what modelers do. So it's about estimating the cost of treating cancer to feed to pass on to modelers as input in decision modeling. So this work uses NHS routinely collected data. And another important dimension, other than stage of disease, is also socioeconomic inequalities. We know that there exist clear socioeconomic inequalities in cancer early detection. We know that people who live in the most deprived areas of the country are getting diagnosed later, but we don't know how deprivation affects cancer treatment costs. So we need to investigate that, and we need to take that into account when conducting economic evaluation. And also another dimension that we need to take into account is ethnicity. We need to look at inequalities in terms of ethnic group. So there are two challenges. There are two challenges to this, to estimating, to using costs for economic evaluation. Firstly, current cost estimates are outdated, and they don't distinguish between early and late stage disease. And we also lack visibility of the full care pathway. Cancer occurs across multiple NHS settings. It occurs in primary care, secondary care, and in specialist treatment services. So it's been historically difficult to observe the full care pathway and capture costs across the primary care, secondary care, and specialist treatment services. So we aim to do this using linked NHS data. The primary database for this work is the CPRD ORM, the Clinical Practice Research Data Link. The CPRD ORM, some practices that use the IMIS software, electronic health record system, submit data to CPRD. The data are pseudonymized, they are not non-identifiable data, and they are submitted to CPRD. The cancer registration data, which includes staging and SACT and RTDS data, they are also submitted to CPRD directly, using again non-identifiable information. So these data sets have a CPRD specific unique ID that enables linkage across data sets. And we also have access to hospital activity through HES, which includes inpatient admissions, A&E attendances, and outpatient visits. And the way this works with the hospital activity data is that NHS trusts send data to NHS Digital, which has now been renamed to NHS England, which acts as a third trusted party and links the hospital records to the primary care records, and through the CPRD specific unique identifier, the data are passed on to CPRD. So we have a very big and broad data set that links across primary care, secondary care, and specialist treatment services. And of course, this also includes information on deprivation and ethnicity, which are the other two dimensions of interest alongside staging. So what the data let us do? The data let us use information on healthcare issues use, including imaging, surgery, radiotherapy, GP visits, hospital admissions, A&E visits, and outpatient attendances. We plan to estimate the cost per patient to the NHS and quantify the use of healthcare resources for 4 types of cancer. These are lung, cervical, breast, and melanoma. We aim to estimate the cost by stage and diagnosis. We will also assess how costs and resource use vary by socioeconomic status, which is represented by the index of multiple deprivation and ethnicity. And this is the analysis plan. I don't have any results to show yet, but this is still ongoing. So we plan to use the CPRD Aurum, which is one of the largest primary care databases in the world. It includes approximately 20 to 25% of Finland's primary care population. It enables linkage to hospital admissions, outpatient visits, ARE data, cancer registration, and treatment records. For this work, we will use contemporary data between data that was extracted between 2018 to 2023. And we will include all lung, breast, cervical, and melanoma cancer patients. We will analyze them by stage, diagnosis, and level of socioeconomic deprivation and ethnic group. We will use 2 approaches for our analysis. We will first, quite straightforward, estimate the cost of care across GP, hospital, and specialist treatment using standardized NHS reference costs. And then we will match those patients who have cancer to non-cancer patients and then compare costs, do a comparison of costs between those 2 types of patients to isolate the true cost that is attributable to cancer. And thank you for listening.
I won't touch your water. Hello, everyone. So I'm Catherine. I joined the University of Manchester as the only health economist in 1994. Prior to that, I was a hospital pharmacist working in hematological and cancers. So yeah, it's just amazing to have so many people here talking about the economics of cancer today. It's quite a cool moment. You're supposed to say she doesn't look old enough to anyway. This yeah, I got slightly volunteered to talk about this. This is an emerging area for health economists, trying to think about how we balance economic and also environmental impacts when we start to look at healthcare interventions. And if you look at what's the key driver for this, it's top down, and it's been that the NHS has been charged with maybe acknowledging some of its responsibilities. So one of those is that it's responsible for 4% of the UK's total carbon footprint. And so as part of this, the NHS has made a legal commitment to reach net zero by 2040. But that's for the emissions it directly controls. There's other targets for emissions that it's indirectly responsible for, but let's focus on the ones it's directly controlling at the moment. So that pie chart sort of represents some of the breakdown and where you are getting these carbon emissions from. So if you think about a very simplistic pathway, if you like. So if you're looking at things getting into the NHS, there's some new intervention development. That might be a medicine, it might be a diagnostic, it might be a surgical procedure. That will be informed by some trials, so preclinical and clinical trials. The intervention gets ready, so it has to be regulated, and then there's some form of appraisal by NICE, or maybe the National Screening Committee if it's a screening intervention. Then it gets into practice, and then nurses and pharmacists start choosing what they want to use. And then there's the use in practice, so it then becomes embedded into care pathways. There's a carbon footprint to all of this. There's also, I have a carbon footprint, you have a carbon footprint. This mandate that the NHS is going to make itself net zero is massive. It's a huge ask, really. People are starting to look at it. So NICE is starting to think about that climate change, labelling it sustainability. I've got a little slide on nomenclature in a moment. It's also as part of something called a Health Technology Assessment Innovation Lab, methodsy stuff, that's what they do, has started to think about how you might include the carbon footprint as part of its appraisal processes. And it actually did a mock technology appraisal where they looked at the carbon footprint of a new medicinal product. I don't think I'm sort of killing anyone's thunder here by saying, well, it didn't work. So yeah, so most of my presentation is going to be how hard this is, and where how far we've got, and where we want to be in the end. So yeah, a note on terminology. I do this myself. I interchange sustainability, environmental impact, climate change, carbon footprint. I'm not an expert in this area, and so I have to be really clear in my head about what are we talking about here. So Alice Copson, who's in the audience, she was in the audience. She's moved. She's test. So Alice produced this slide to help me really to think about when we're talking about some of these concepts, what do we actually mean? We're actually interested in a very small bit of that overall nomenclature system, which is the carbon footprint and how that directly interacts with climate change. And when we talk about a carbon footprint, we mean how a product, so that might be a healthcare intervention, contributes to climate change by providing a measure of the number of kilograms of greenhouse gases. And quite specifically, probably carbon dioxide. So they turn all the greenhouse gases into these carbon dioxide equivalents, and it's measured in kilograms. That's important when we come to the next bit. There are also some people who are starting to think about, well, what's the social cost of this carbon? Where they're trying to turn this additional carbon footprint in CO2 into a monetary value. We don't actually know what this number is. And so if you look at the literature, people are banding numbers left, right and centre about what is the social cost of carbon. That is problematic for us when we try and do our economic evaluation. Right, so I'm going to go over some ground that Gabriel and Stu's already mentioned, but I need to do this to try and remind you what the challenge is here. So when we're doing a cost effectiveness analysis, you might get your data from a trial, or you might want to build a model. So there's two different types of getting some numbers about costs and effects. So you have some process, so it might be a new medicine, or it might be a new screening intervention. And because of this thing called opportunity costs, you've got to compare it to something else. So these are your relevant comparators. You're pouring in your inputs. So these are the costs of A versus B. And then you get your outputs. So these might be measured in quality adjusted life years, which are a composite measure of the benefits and the harms that you get from your intervention. And then you get some result. So your result is how much does the new thing cost? How much does your comparator cost? And you're interested in the difference. And then how many qualities do you get from your new thing? And how many qualities do you get from your comparator? And you're interested in the difference in the qualities. And you put this onto your cost effectiveness plane. So what you're trying to do here is solve this dilemma of whether your costs and your qualities are balancing. So this is your dilemma, okay? And you have some options here. So if you fall into the northwest quadrant, you would never go ahead with your new option because it's costing you more and you're losing health. If you're down in the southeast quadrant, happy days, you're getting more health and it's cheaper than what you're currently doing. The two starred areas are where you have to calculate your incremental cost effectiveness ratio, which is how much you have to pay to get your extra quali. This is where the famous NICE threshold comes into play. So what you want is that ISA to be less than your £20,000. Or is it 25? We can talk about that if anyone's interested. Don't ask a health economist about the cost effectiveness threshold. You won't shut them up. So we're at this dilemma at the minute. We're not talking about carbon footprinting yet. We start to think about this carbon footprint. We're going from a dilemma to a trilemma. I was very proud of myself when I thought I'd invented a word, but I haven't. It does actually exist. So you've got this, you're in this difficult position now where you've got your healthcare costs, you've got your health benefits, qualities, and then you've got your carbon footprint. What do you do with that? So we're working with a number of people who are brilliant at calculating the carbon footprint. They know how to do that. We can calculate the carbon footprint of hyperfractionated radiotherapy. Joe's already alluded to this. They came to, Rob Tutor came to me and said, the funding body, NIHR, wants to include an economic evaluation alongside this. And I just laughed and I said, really? I said, that is quite hard, you know. So this is what we're trying to tackle at the moment, is how to include this carbon footprint alongside our cost effectiveness analysis. So there's loads of literature coming out about people offering solutions. So there are solutions, but there isn't an answer yet. So if you think our acronym CITI wasn't bad enough with an ISA, they've developed a new one, which is an incremental carbon footprint effectiveness ratio, which is ICFR. I don't even know how you say it. ICFR, maybe, ICFR. So what that gives you is you go away and you measure, it's incremental, so you've got your new thing and you've got your old thing. You measure how many kilograms of CO2 you've got in your new thing and your old thing, and you calculate how many qualities you've got. Then you divide your carbon footprint bit by your qualities. But what does that even mean? You know, what is that? How does that help you make a decision? So you're trading off your carbon footprint now with your health gain now. And the time frames are wrong, the metrics are wrong, not helpful. So the other approach someone has said is, well, let's think about adjusting this quali. So let's ignore the cost side. That's just too hard to think about at the same time. Let's just look at the quali side. So then you think about calculating the future health damage from the carbon footprint that's happening now. So you basically adjust your quali. So you've got your qualis now for your patient, and you do some magic numbers, a lot of hand waving, and you generate your qualis for your greenhouse gases in the future and take them away. And what you want to see is that on balance it's positive. So you get, so that's another approach that's being suggested. The last approach is the one that we're taking, me with Alice, which is at the moment, which is the simple approach, and Joe in his imprint study, is let's just focus on the healthcare costs, at least get that bit right, and also think about the costs from the carbon. You can actually, if you use your social cost carbon, you can transfer your kilograms of CO2 emitted into a cost. As I've said, we don't even know what the social cost of carbon is, so you take lots of different numbers and see what happens if you
used lots of different numbers. So then you, to your decision maker, you present the difference in your healthcare costs and your difference in the carbon costs. At least then they've got transparent evidence about how they might want to make a decision. So at the moment, all my work is with Rob. So Rob for me is the font of all knowledge about anything to do with carbon. So I go to Rob. I have actually done a sustainability course, which took me 4 hours. That obviously makes me an expert. So I don't actually know anything about the carbon footprinting side. What I can contribute to this is how we might start to think about putting these numbers alongside the framework of cost effectiveness analysis to enable us to make a decision. So Alice is doing a PhD on this. Joe is working on the hyperfractionation work with us, really trying to create a really fancy model that represents the current clinic and sees what happens if you disrupt that clinic by using fewer courses of radiotherapy compared with the current 15, and see if that creates cues in the system, but that might also have a positive impact on the carbon footprint, because patients don't have to drive the cars and come to Christie and they're burning greenhouse gases for all of these extra treatments. And Tonya is also working with us on this. Tonya is our backroom girl. I wish she was here today, but she's not able to be present today. So Tonya is really pulling all the information together, talking to lots of different people, making sure we've got the pathway right, and also collating all the resource use and the carbon, and then combining that with the carbon footprint data that Rob will produce. So what projects are we working on? I've written a piece, which is, well, why she stood up here, saying, should we pay for carbon reduction with health budgets? So this is led by a health economist called Andy Briggs. The answer to this, I think, is no. What I mean is, if you think about the product development process, so if you look at a medicine, who should be responsible for thinking about the carbon footprint of that medicine? Should it be the NHS? I don't think it should. I think it should be the manufacturer. So if you line that with health technology assessment processes, should we be looking at the carbon footprint as part of the HTA process? I argue no. You should be doing it prior to that. Up to the point, you should not even be regulating medicines if they are having a negative impact on the climate. So this is what we're saying in this paper. It shouldn't come so late. Now, it's a different question if you've already got a healthcare intervention in place. So here we've got an example of breast screening, for example, and this is the focus for Alice's PhD. So if you've got something that's already in place, how might we think about modifying it so we influence the carbon footprint? So could we do better with something like breast screening to reduce that carbon footprint? So that's what Alice is looking at. She's also interested in what decision makers think about introducing carbon footprinting alongside cost effectiveness. So she's talking to the National Screening Committee as well to see what they think. And the blue box represents the imprint study that we've already spoken about. Yeah, so that is me. As I say, I'm not an expert in this space, but it's an important space, and more and more you see more and more people thinking about carbon footprinting when they're looking at new healthcare interventions. So thank you.
Okay, yeah,
No charge.
sure. You need this?
Just very much. I just don't flip over the wire.
I just don't want it to all
I won't go this way. Brilliant. Thank you. Thanks, Catherine. Hi, everyone. I'm Sean Gavin, a senior lecturer in health economics here at the centre. So I do a lot of model-based cost effectiveness analysis work, thinking about how we can demonstrate the value of new interventions in cancer and across lots of different indications as well. But increasingly, I'm doing a lot of this work a lot earlier in the development pathway and translational pathway of interventions. And I guess the purpose of my talk today is to try and convince you that that's a good idea, to be thinking about embedding health economics much earlier in translational pathways. And hopefully through the talk, I can give you some examples of how we can do this and how we can start to think about developing economic evidence to move ideas towards patient benefit and implementation within the healthcare system. So have a think about how we go from conceptualizing an idea of a new healthcare intervention all the way to it impacting patients and benefiting patients within a routine healthcare setting. It actually takes quite a long time to do that. I'm not sure exactly what the current research says, but it's usually around well over a decade to go from an initial idea all the way through to patient benefit. And underpinning all of this is really a chain of sequential research and development decisions that have to be made to move any intervention along the translational pathway. So just by way of example, this is a really stylized example of what you might see in medicine go through. So you might go from some basic science, so some preclinical work to identify drug targets. That might then move you into first in human trials to look at safety of those new molecules. That then might translate into patient trials, so phase 2, phase 3. And then we tend to move those positive interventions towards clinical practice where more sort of regulatory and health technology assessment decisions are made. That's for a drug. If you could take any intervention though, you could have a similar pathway for a diagnostic, for a sort of digital intervention. So I've looked at some app-based interventions in the cancer space. And again, you might start with an early prototype version and then think about moving that towards regulatory approval as a medical device. And then scaling that up once you get approval to sort of bigger populations across the country. Again, sort of sequential decisions to move you along that pathway. And increasingly, if you think about maybe reorganizing services and workforce and delivery of healthcare interventions, so maybe shifting things towards community settings or outpatient settings. Again, you wouldn't go straight into that in a full translational, straight into practice. You'd probably start a small pilot and then scale up. And the challenge we see is across the whole pipeline, across this whole pathway, many interventions fail to move from that sort of basic science to first in human or from first in human to sort of a more pivotal trial. And one of the reasons is that the earlier you are in that translational pathway, the risk is much greater to funders, to developers. And so what we need to start doing a bit more of is thinking about embedding risk mitigation strategies a little bit earlier in that translational pathway, so we can then start to build a bit of a case to move closer towards patient benefit down the line. And I think we have a role to do that as health economists. So what's driving that risk earlier in the translational pathway? And for me, it's driven by uncertainty. So earlier in that pathway, you need to have a strong signal for clinical benefit of whatever the intervention might be. And that's going to be paramount. That's never going to change. But increasingly, we're starting to hear claims or requests from funders, from developers of any evidence of economic viability, even at this really early stage when we might be identifying new drug targets or thinking about repurposing drugs. This question of economic viability or sustainability or value to the healthcare system sort of goes hand in hand now with, have you got any early signal of clinical evidence? So what we're really asking here is there any indication that this new idea could be cost effective for the healthcare system? Which is a tricky question to be answering when you're so early on in that translational pathway. You might be in a position where there's just no clinical evidence at all to support that statement. But we know that people need an answer to that now. So I've just put some boxes up here of all things that come to my mind when I think about what drives the answer to this question about, is an intervention cost effective? And it's going to be the potential effectiveness of your new intervention. It's the safety profile. I've got population size here, but maybe the characteristics of those populations, those individuals, who should we be targeting this intervention for? The cost of the intervention and any downstream consequences of being prescribed that new technology, quality of life, health utility, and then understanding whereabouts in the care pathway any new idea might actually fit, and what does it displace in current practice, or does it go hand in hand with some existing interventions as well? All of these will drive the value proposition of a new intervention. And so we can start to think about from an economics perspective, can we start to generate some evidence of these at quite an early stage to then help move down those translational gates in your pathway. So we need to be starting to tackle these uncertainties much earlier in the pathway. And what we tend to do now as health economists is think about our techniques in an iterative sense or a sequential sense. So rather than being brought in at the very end where an intervention already exists and it maybe goes to NICE and we develop some definitive answer about whether this is cost effective, yes or no, actually we could take a few steps back and start to partner with clinicians, with scientists, with patients at a much earlier stage in that development pathway and start to build this evidence at a bit of an iterative pace over time. And the key thing to think about here is what evidence do we need right now that's going to help us unlock that next stage within the translational pathway and help us move along to that next step. So here's our pathway again here. And just to get you thinking, some things we can contribute to at this really early stage when you're sort of doing preclinical work is to think about establishing need in the healthcare system. So can we put some numbers on how much is this intervention in this particular population, how much is that actually needed? And then once you've maybe identified drug targets or have a prototype of a new intervention, we can then start to think about, well, can we put some numbers on it to justify a first in human trial? Can we get some early indicative evidence to say that this could potentially be cost effective if the effectiveness is greater than 50% or the accuracy of a new test is in the sort of 80% sensitivity specificity range? So that's the type of work we can do there. And as you're getting closer to patient benefit and you're getting closer to those definitive trials, we can then start to shape what type of data collection we should be really embedding within those pivotal phase 3 trials. So what are the key data targets we should be collecting data on? What do we maybe need to deprioritize because that's not really the key uncertainty and that's not driving the decision? And hopefully by doing that, you have a strong clinical evidence development pathway that goes in parallel with really strong economic evidence as well that you're building up sequentially. And the two of them are then seen in parallel, and hopefully together they help support that eventual adoption decision to get things into practice. So I'll quickly run through some of these. So just on this establishing need point, we can do work like understanding the cost of illness for an existing health condition within current clinical practice, or understanding the burden of disease. So what does quality of life look like at a population level? And then trying to maybe simulate some potential population sizes, which really helps with capacity management and demand management within the healthcare system. So understanding that early is really helpful for a few years down the line. On this point about justifying development, we can start to explore alternative ways to deliver healthcare services within care pathway analysis. And we can start to think about some indicative price levels that any intervention can't really exceed, because that's the most the healthcare system would be willing to pay for that new drug or diagnostic or screening program. And we do extensive sensitivity analyses around that space as well. And then finally, as we start to move closer to our definitive trials, we can start to do some exploratory model-based cost effectiveness analysis to identify where the key uncertainties are and quantify that. Maybe do some exploratory budget impact analysis so we have evidence for commissioners to see this is how much a new intervention might cost in your trust over, say, a 1 year or 2 year financial period. And we can start to explore whether any further data collection is valuable. So there's a technical value of information analysis, which allows us to quantify is longitudinal data collection or observational data collection worthwhile post-trial. So I've got a couple of minutes left, so I'll just very quickly give you an example. So this is from a couple of years ago. So this is some work I did looking at tumor infiltrating lymphocyte therapy for advanced melanoma. Some work through the IMATCH program here in Manchester. So at the time, we didn't, the guidelines for melanoma changed, so the pathway shifted slightly, and we didn't really know how many patients would be expected to receive TIL therapy nationally, which is a key question to understand because actually it takes a lot to have capacity for beds, apheresis units, and the turnaround time to manufacture these therapies as well. So we started to map out where we thought TIL therapy would enter into the advanced melanoma pathway. So this is really sort of back end of the pathway after you failed all existing lines of therapy. And then At each of these transition points in the pathway, we could use we use trial data here, but you could also use local observational data to try and understand at what point patients will experience progression or mortality and transition to the next treatment. And then we can start to scale it up to national incidence data using the cancer registry. And so we ended up with a simulated value of around about 170 patients per year will become eligible for this, which when we ran it by the team in the Christie, that's felt about right once you start to slice it up across the different centres who could receive these treatments. So really useful evidence to understand demand management capacity within the system. And then very finally here, Gabriel mentioned this a little bit earlier in his talk about modelling and extrapolation, but we can do something very similar at early phase stages of development as well. So this is using phase 2 trial data for a really small sample of patients from a single arm trial. And we can start to extrapolate what we think might happen if we reach a cure in these patient populations. So this is then linking that short-term phase 2 trial evidence to longer-term observational data from, this is American registered data here, and ONF's all-cause mortality as well. So it gives you sort of indicative evidence of what we think a lifetime benefit might look like for some of these patients if the treatment's successful. Recognizing there's uncertainty in that as well. So if we think there's different rates of cures in these populations, we can then sort of move that up and down and see if we should shift the cure fraction in that population, what does that look like in terms of average overall survival in our patient population. So just to wrap up then, my key message, I think, is it's very possible to involve health economists at any point in that translational pathway, even at the point where you're just coming up with ideas and you want to understand, is this going to be valuable for patients? We can help in that stage as well. And the key for me is we can support in these sequential research and development decisions, underpinned by mitigating this risk that's driven by uncertainty at all stages of the translational pathway. And hopefully you build this strong case for adoption that brings the clinical evidence in parallel with the economic evidence at the same time. Final point to mention, if you just want to deep dive into this, there's a piece I wrote last year on this topic. So it kind of talks around some of my thinking on this and links into some key papers. So it's worth a read if you want a coffee and have a chat about that later too. But I will leave it there. Happy to take questions. And who am I handing over to? Did you? Yep, that's just you. So thanks for your time.
Okay, so I'm not John, but one of the things we want to talk about is trial-based analysis as well. And this is actually something that we all do, again, sort of similar to modelling. We all get involved in bits and pieces of this. But the reason I'm putting John up there is John is joining us soon as a research fellow, and his job is going to be basically to do trial-based analysis. And that he is joining a joint post with MFT. So John is going to be the guy to go to, basically, if you're interested in learning more about this. So trial-based cost-effectiveness analysis. So we talked a lot about modelling today, and that is something that is really useful in bringing together evidence from lots of sources to extrapolate survival and all the other just all the other weaknesses of trials that Gabriel mentioned. But sometimes there's no substitution for getting that primary data from trials, and so for particular in terms of the health economics, things that are really critical for us are understanding quality of life of the actual patients who are going to benefit from an intervention. So particularly, getting that raw data from patients in this country rather than having to draw in data from other similar countries, similar healthcare systems. We want to improve the validity, and also getting actual real world cost data as well for what is the actual resource use that the patients are going, what are the actual resources the patients are using, and what are the actual costs, because healthcare is not perfect. People experience treatments in different ways and end up using different amounts of resources, and so we want, again, accurate data about how people are actually using the healthcare system. And while this is important, often what we will do is sort of do some analysis alongside a trial and then build on that by using modelling as well. So for example, doing some work with Michelle, actually, with Martin Eden, looking at dietary advice for people to reduce the risk of breast cancer. So Martin's done some trials-based analysis looking at quality of life. So collecting the EQ5D, which covers people's quality of life in different healthcare states, and also looking at cost data. And alongside that analysis, we can potentially then look at sort of what's the actual impact of reducing those women's risks of breast cancer long term as well. And so just to highlight quickly some other research here. So I think some research Gabriel's involved with, the thoracic radiotherapy study, and also again some work that Amber and I are hopefully going to be involved in. Michelle, a bid that's in process looking at what's the resource use associated with this intervention of offering supportive text messages for people who are basically recovered from breast cancer. So basically sort of the healthcare system keeping in touch with them and offering reassurance and signposting services that they can access as well. And this kind of is an example where actually more resource use is not necessarily a bad thing for these patients, because it's about appropriate resource use. So we want to understand if they're accessing these resources that are offered to support them if they have any anxiety or if they've got any worries going forward. So this is actually a research proposal that's under review at the moment. So it's just something that I wanted to briefly touch on, that this is something that we can embed in trials, and sort of there's lots of work there. Martin, who couldn't be here today, and I think Sean's done some work in this area as well. So just highlighting that. And that's the end. I just wanted to briefly touch on that. But we are now open for any questions, the audience, or we can look on the Mentimeter and see if there's any questions online. That's feedback. Yeah, I was doing go and see if there's any. Shut down now, so it's. Yeah.
Oh yeah. Oh, I can talk now. So I was talking to Sean earlier because we are doing some more health economics work now in looking at kind of complex biomarker interventions, and I think it's just knowing who to come to as well, because obviously you've got a big department now, which is great. Obviously you still need funding for the work you do as well, so it's not like this is all just going to happen for free. So it's just whether we could look at an approach for if our trainees or people wanting to get involved with the first time, who do we approach? How do we discuss ideas and kind of how to make that happen, really?
Yeah, definitely. I can speak to this, Mike Connor. Yeah, so we'll circulate the slides after. They've got all of our email addresses for each of the different study types. So the other thing we've done now is produce this kind of online tool that we'll share later, that you can filter by kind of research areas and methods as well. So if, say, you're like, oh, I'm interested in working in lung cancer, and has anyone done anything in this area, then you can search for us and again, I think, find our email addresses. One of the things I was wondering about, because we're very heavily involved in the BRC, this is the BRC event, whether there's something that we could do with, having some kind of point of contact through that. For instance, I know, for instance, we have a PPI drop in every month. Maybe we could do something with health economics. So I have access to a hot desk here, so maybe I can come in once a month and people, be available if people want to ask questions, because we're really keen to sort of, because we're based at the university campus, it's just physical distance sometimes makes it hard to just ask these casual questions. So yeah, that might be something I could look into, as having sort of more of a presence down this side as well.
Sorry. We all talk to each other. So if you know one health economist, you'll contact all of us through the system of filtering. I know that's not ideal, but if you know a name, just ask them, and if they don't know the answer, they'll pass you on to someone who does. We are quite a substantive team now, but we are mainly, as you've pointed out, we need the money because most of us are contract researchers. As I know, I said us, I'm not. I used to be. So contract researchers. So yeah, we do struggle a little bit with being perhaps as responsive as somebody might want when they first come to us, but we're very keen in particular to build work around the economics of cancer, which is why we're here today. But any area, yeah. So get in touch and we'll pass you on. And the other thing, we're connected nationally and internationally as well. All of us are connected internationally. So we also, if there's a very particular area of expertise that you're wanting, we probably know someone who has that expertise. Sorry, Stu.
Thank you very much. So first of all, congratulations. This is a real strength of Manchester, and yes, cancer is a strength. This is a strength, and there are great examples, and there are opportunities for future ones. I guess my question and comment is around some of the projects that link with the cancer registries, and I'm interested to see if you guys have a better inside track than I have. The cancer registries and the National Cancer Registry, prior to the pandemic, was quite easy to access, actually, to get individual level data. Two things have happened. It's tightened up its access, number one. And number two, the ONS, of course, was so heavily involved with the pandemic because we needed data so quickly about the pandemic, that cancer has fallen behind ever since, and certainly CRUK data is still stuck in 2019, so it's nearly a decade out of date. And even things that are linked, such as the Biobank and such as CRPD, it still differs between Wales and England, for example, and I have no idea where Scotland is in this equation. So it's a real problem to get actual national data that's representative. So please enlighten us whether you guys have quicker and easier routes into this than I have, because I'm struggling on a rare cancer with anal cancer to get up-to-date data. And we suspect things have happened since the pandemic in viral cancers that may be of interest to the population.
Yes, I think, Chris, you're probably the best to answer this, but I think the short answer is, yeah, it's very frustrating getting access to it.
Yeah, it's actually really frustrating. So we developed the CPRD protocol we started developing the protocol about 2 years ago. And there was a transition happening with the NCRAS data. So previously, as far as I'm aware, the NCRAS data was available through NHS England and the NHS Digital. So we didn't go in that route. We went through CPRD. So before, it was the case that NCRAS could be sent to CPRD through NHS England, but now there is direct route from NCRAS to CPRD. So actually, CPRD will have the data in-house. They've been telling us that they would have the data in-house for the past 6-7 months. So it's obviously it's taking a long time, but the last time I contacted them, they said they will have the data over the summer. So after that, the data will be available through the ERA portal, which is where you apply to get access to CPRD linked data, and yeah, hopefully that will make access easier. So it's only through CPRD. That's 25%, but CPRD, in terms of the population, is representative of the age and sex of the population. It's also representative in terms of deprivation. So it's not perfect, obviously, but it's something.
Questions?
Hi, thank you. My name is Pao. I am a clinical fellow in eProms at the Christie. And what I'm interested in currently is the health economic of proms. And I hope that one day in the countries we can use proms across the country, not just only at the wealthy centers like the Christie. I have a few questions actually, but I'm going to ask only two. So one thing is, I noticed that when we talk about health economic evaluation, they usually compare intervention within one target groups. But as you, like Stuart has said very nicely, that when we fund one service, that might mean we have less money for another service. And let's say if we have two intervention, we have two evaluation that has a result, they're both cost effective, but obviously they were done in specific target groups. How decision makers decide which one to fund and which one not to fund, especially when the data we have is only from individual settings, not overall setting.
Gabriel? Yeah, good. Probably easiest to come up with.
So conceptually, I have a bit of a problem with both cost effective. And actually, health economics doesn't have a very good toolkit for this. But in principle, you can have multiple comparators in a decision space and have very good rules about what is the optimum within that, but not very good rules about, well, what else might be worth doing as well. The question about which option you would prioritize given a fixed budget is a question about the amount of value they deliver, and in effect you end up with one option having better net benefit than the other, and then you can look at strategies that are mutually exclusive approaches to adopting one thing, adopting the other thing, adopting both things, and working out what the additive value is for that. So that's all doable. However, I mean, the point you raise overarching that about what's the generalizability from one setting to another is something we always wrestle with. And I think I argued in what I presented earlier that one of the strengths of economic modeling is you can be very explicit and transparent about what population you are trying to simulate to start with. And so if there are simple things that you can do, like, you know, the population that you've got some evidence in was younger than the other, and you know what your target population is, well, you can standardize that and say, I want to know what it looks like in my population. Obviously, there are more complex differences than that as well about the ways in which systems are set up. I guess the economist's toolkit for that is constrained by how much evidence there is about what the differences are and what impact they might have, and I guess that's a non-trivial hurdle to clear in lots of cases, but it might in principle be possible to know how pathways differ between different settings, and to be able to account for that in your simulation of what you're trying to do. Always you're trying that. So it seems to me there is no point in asking, was something cost effective? There's no point in asking, for that matter, was something effective? The only reason you'd want to take inference from evidence is to guide some future decision. And so we will always want to simulate the population that we think the decision applies to. And that might be one of your populations, it might be the other one, it might be neither of them. But you'll always want to get the best estimates you can for those people. Yeah, go on.
Now I have more questions, but I'm going to pick up that after the sessions. But my second question is about the carbon footprint that Catherine was presenting earlier. So I am certainly not sure how the carbon footprint was incorporated into the modeling, but I assume that patients with higher utility scores might end up having a higher carbon footprint down the line. And
so I've obviously done a very poor way of explaining what we're currently trying to do. At the moment, the carbon footprint, Rob does his carbon footprint analysis. Alice does her economic analysis. And then we try and think about how to bring the two together. So at the moment, we can't incorporate carbon footprint into the modelling.
Mm.
You do your modelling or you do your trial and do your carbon footprint, and then you have the results at the end, and you give them to a decision maker in a way that they can understand how to make a decision. So higher carbon footprint, lower NHS cost, higher qualities. What would you do? That help?
That makes sense.
Yeah.
Okay. Yeah, it makes sense. Thank you.
To answer that question, ask Rob Tutor. If he's online, sorry, Rob.
Does anyone have any last questions? Or I think we're getting near to lunch, but back in.
I'm the one with the question. My name is Betha. I'm the one with the question on the screen. My question was really, is it limited to just patient, or do you look at the machinery? I think that's what I'm trying to understand.
I think so, linking to the carbon footprint thing, but it would be anything involved in the delivery of the intervention. It'd be both sides. You're going to say, ask Rob.
So what we've not explained today is when you're looking at, if you're thinking about the costs to a system, you have to be very clear what system you're interested in. So most of the analyses we do, we focus on the costs to the NHS, and we're very clear about which bits of the NHS we mean. So do we mean only general practice? So I think Christos alluded to this a bit. Are we interested in the cost of general practice, or the costs to a general hospital, or the cost to a specialist hospital, or across the whole NHS? Are we including social care costs as well? So when you're looking at that question and carbon footprinting, there's a similar analytical thing that you have to do in your head. What is your perspective, and how long are you following things up for? What's the time horizon as well? So we're only looking at current generations or future generations. So you when you set out your analysis, you have to be very specific about what your focus is, both in terms of perspective and time horizon. That's for economics and also for carbon footprinting. So the answer could be possibly. Please don't ask me how to do it, ask Rob.
Okay, any other questions? No.
Can't remember who it's from. But in surgical trials, and it's changed sort of over the last few decades, you often have a decision whether to test a new intervention in a pragmatic environment or in an environment with optimum conditions. So I guess based on what you've just said, my question is, when NICE are deciding whether or not something is fundable, the analysis that's been done to calculate the cost of the quality, do you unpick where the trials that have been done have been completed and whether they're pragmatic versus ideal scenarios? And if you're designing a trial now and you were doing a health economics checklist right at the beginning, where would you advise, a surgical researcher or someone researching in this space to start thinking about how they might set up the trial?
So yeah, certainly within that kind of NICE decision making, one of the things that often takes up a reasonable amount of committee time in that process is thinking about the extent to which the evidence that has been collected generalizes to the decision population and the setting of the decision in terms of what the providers, how they're set up. And there are simple ways in which, and I said in my presentation, like one really simple thing we might often do within an appraisal is like make sure that we use trials for what they're good at, which is establishing relative effects, and use real world evidence for what that's good for, which is establishing what the population looks like in practice and what the expectation, the absolute expectation might be. So there are ways of combining those, especially within decision modeling. Ultimately, decision makers will, as I said a moment ago, always want the best evidence available to them that reflects the world in which the decision applies. And if data can be collected in a way that is clearly generalizable to a valid decision population, then I guess that will always be optimal. On the other hand, the value of the experimental method in terms of being able to isolate signal from noise and find the true independent effect of the thing you're interested in causally, you wouldn't underestimate the value of that either. So in your ideal trial, you do both. You have a perfectly representative population that's beautifully controlled, such that you get an estimate which is immediately valid to your decision problem. Anything other than that, assuming that isn't possible, is about splitting the difference and trying to work through what the likely benefit is of setting up research that enables you to detect the thing you're causally interested in, against how the increasing messiness of the pragmatic world is going to both increase generalizability, but maybe jeopardize being able to find that causal relationship. And the cop-out answer is, it depends on what's possible and what you're trading off in any individual case, I guess.
Thank you.
Okay.
Great. I think we'll finish there then, because we're running 10 minutes over. But just to finish, just to say thank you for coming. And again, please do get in touch if you have any questions. We'll send around the slides that have everyone's email addresses on, and also the device for exploring our research as well. So thank you. And yeah, also there's some lunch available. Please do come and talk to us as well. Thanks.